Hello, good evening. Nice to be with you once again. And of course, we're here with Moving Forward, and I'm Abdul Ali.
And I am Dara Hamilton, and I'm so happy to be moving forward again with you today, Mr. Ali.
Beautiful, no question about that. And today we want to talk a little bit about the heart. That's right, because we all need the heart to keep us going and living and growing. And so we have had the opportunity to ask Dr. Dante Galiber, who is at the Heart Center, and he's also the Director of Cardiology at the One Louis Hospital, to be with us tonight to just tell us a little bit about the heart. How does it work? Are there tips that we could get to see that it's not working and working properly? And if it's not, what could be done to bring it back to life? Because my limited understanding of the heart is that if your heart is not working, or if your heart stops, it's going to be a challenge to get it going again and for you to be able to live. So just give us a general overview, Dr. Galiber, about the heart, and then we could get to some specific questions.
Thank you, Mr. Ali. I'm Dr. Dante Galiber, and I'm a cardiologist. I work at the One Louis Hospital. I also have a private practice at the Heart Center PC. The heart is a very important organ, and actually every organ is very important, and the ones that are not functioning can have a deleterious effect on your body, of course. And so but the heart is the organ that I study the most, and it is the main pumping chamber or main pumping organ of your body. So it pumps all the blood to your body, and it is a very selfish organ. It actually supplies blood to itself first, which it probably should, and then the brain takes most of the blood supply from the heart itself as well too, because the brain is a very important organ as well, and one cannot exist without a functioning brain. But the heart, there are many aspects of the heart that we have to look at as cardiologists. We have to look at the electrical activity, the mechanical activity, and the valvular activity of the heart. And we study the heart by doing EKGs. And an EKG is an electrocardiogram, and where we actually study the electrical impulses of the heart itself. Another study that we do as well at the One Louis Hospital is an echocardiogram, and that's a sonogram of the heart, where we evaluate the structure of the heart, the muscle, the valves, the aorta, and the degree in which valves are stenotic or narrow, or whether they're regurgitant, meaning a leaky valve. And so we can often tell what the problem is with somebody who has an abnormal heart looking at their echocardiogram. And because one of the most important things is the function of the heart. So if it has good function, we consider the normal function to be 55 and up for the heart. And so if somebody has an ejection fraction of about 10%, that's severely decreased function. If their function is between 30 and 40, it's moderately decreased, and 40 to 50, it's mildly decreased. And so so function really is important for us to look at when we look at the heart too. So we can also look at all the valves. There are 4 valves of the heart, and each valve can leak or can be stenotic or narrow. And so we often see a number of these problems in our community as well too.
Dr. Galiber, the heart is the center of our body, right? And I sort of wrote down that the heart was the second to the brain, I can imagine, in keeping us alive. Is it really?
Well, I think that every organ is important for its own, with its own merits, and the brain is a superior organ for which all other organs subsist to serve, and without the brain, really nothing else functions. So actually, the brain controls the heart in terms of the heart rate, and so there are lots of innervations, lots of nerves that actually innervate the heart and regulate the heart rate as well too.
What made you interested in studying or focusing on or specializing in knowing about the heart?
Well, actually, I was somewhat fearful of cardiology when I first started, because it was very fast-paced. But then once I took the rotation, I thought it was very interesting. And because it was fast-paced, I liked it as well, too. And it's very logical, I think. And being a cardiologist, you really have to know a lot of things about the body itself, too. So we can actually take care of patients who are very sick in the intensive care unit, because the cardiologists, they are often called upon to assist the intensivists who are in the intensive care unit taking care of patients. And so,
That's interesting.
yeah.
Well, certainly very interested indeed. I think one question I'd like to get a little sense of what's happening heart-wise in the U.S. Virgin Islands, the statistics, what numbers are we getting for St. Croix, St. Thomas, St. John, Water Island, as compared to the U.S. mainland in general?
I think the numbers are good. We actually have lower rates of cardiovascular disease than in the United States. And so we run probably 4% risk of cardiovascular death in the Virgin Islands, and compared to the United States. And I think part of it is because a significant number of Virgin Islanders do not smoke cigarettes. And I think that is the key factor. So there are a lot of risk factors for cardiovascular disease. One of them is smoking cigarettes. Those other ones are hypertension, high blood pressure, high cholesterol, family history as well, and inactivity. Obesity is also another risk factor for cardiovascular disease too.
I would have thought that we would have had higher rates because sometimes our diet contributes to different conditions, and I don't know where we are with respect to obesity and so forth, but I think that's such great news to hear that we have actually lower rates of cardiovascular disease. That's encouraging.
Yeah, so I think what happens is that even though we may have higher obesity rates and probably higher cholesterol rates too, is that I believe that the smoking actually modulates or changes the cholesterol and makes it more aggressive and what have you. And so
Amazing.
and plus we live in a great climate as well too, and I think that living in the States
What about
with
drinking?
drinking alcohol, that can affect the heart. Actually, it affects the muscles of the heart. So individuals who have cardiomyopathies or weak hearts, and let's say they have normal coronary arteries, we advise them not to drink alcohol because alcohol is actually a toxin to the heart. It's a toxin to the liver, and really it's a toxin to our bodies as well too. Probably the only liquid we should drink is water.
Can I ask you a question about that? Because I feel like I read something years ago, and then when I tried to clarify it, it did come up with exactly what you said, that alcohol affects the heart and the muscle of the heart, that it weakens it.
Yes.
Does it also affect us if it's absorbed through our skin, like through hand sanitizers and stuff like that? Does that also affect our muscles? I started to think, are we weakening our muscles with all of it?
Well, I would say
kind of a random question, so forgive me.
I think in moderation, probably using alcohol on your hands is probably okay, but it is absorbed through the skin. And whether it reaches the central circulation, I'm not sure about. But definitely it would get into the subcutaneous or just below the skin level in terms of,
What
if you use
about
it
young
topically.
people in general, say 16, 17, 18
Yes.
years? What do figures look like for them? Do you get
In terms of cardiovascular disease, they often do not have coronary disease. So coronary disease is a older person's dilemma, and it's really because of what we've done as youngsters. And so it takes a while for cardiovascular disease to develop. However, there are congenital abnormalities that individuals can have too, meaning that they're born with them.
Yeah.
And so individuals can be born with valvular problems. In other words, they may have a narrow valve or a leaky valve upon birth, or they may have what we call rheumatic heart disease. And so they develop let's say they have a throat infection, and that is not treated, the pharyngitis, acute pharyngitis, and it's not treated. And then so what happens is they actually have destruction of their valve, but that takes about maybe 20 years. And so in about 20 years, they may present to the hospital with congestive heart failure because they have mitral stenosis, which is a narrow valve of the mitral valve. And so these individuals may present, first with a stroke, or with atrial fibrillation. And actually, when I first got here, I saw a number of patients, actually one person in particular, who actually had a stroke, and she was probably in her 20s. And she had actually had a stroke, but she actually had mitral stenosis. So that is a rheumatological problem, a rheumatic problem, and that needs to be addressed efficiently and correctly.
Is there an age where we should start becoming a little bit concerned about our heart, where we should start paying more attention to it?
I think the earlier the better, because you are really the result of all the insults that you've done to your body, whether it's eating fast foods, and not exercising. And so the individuals who are well trained, they're athletes, and they eat a well balanced diet. 40, 50, 60 years from now, they're going to be doing well. So as long as they're not smoking as well too. So, so do not pick up the habit of smoking at any age.
Absolutely. What about males and females? Are more males affected with heart problems as opposed to females?
Yes, more males and actually at a younger age, and women are protected because of their inherent difference than men. They have menstrual cycles, and so they can actually lose iron on a monthly basis, and so iron is a risk factor for heart disease too. So in other words, women after women reach menopause, their risk of cardiovascular disease approaches that of men.
Interesting.
And so men do not have a natural way of getting rid of excess iron.
Interesting.
And of course, iron, you mentioned that as something that is needed in the diet. That's
Yes,
pretty good. Yeah.
But too much of anything is bad.
Right.
And so you need to have the adequate amount of iron for your hemoglobin. And so that is the central metallic chemical for hemoglobin. And hemoglobin carries oxygen to the rest of the body.
Absolutely.
Dr. Galiber, we hear a lot about high blood pressure, but not a lot about low blood pressure. So, my blood pressure tends to lean toward being low, usually pretty good, but sometimes low. Can you talk a little bit about low blood pressure as a condition? Do you see that often? And is it concerning, and when is it concerning?
That's a very good question. So we as cardiologists and really all other doctors, we try to lower the blood pressure to the optimal range. And so that range is between 110 to 130, the systolic is the top number. And however, individuals who have very low blood pressure, they may have a low blood pressure due to a reason, meaning they're either losing blood, they're in an accident, let's say, and they're losing blood, or they have septic shock. They have an infection that has taken hold in their body, and their blood pressure is low. So those are the outliers that we address by them being in the hospital. Now, young individuals, typically women and some men as well, may have low blood pressure. So a low blood pressure is anything less, a systolic blood pressure less than 100. And so it all depends on the patient too. I mean, if they can survive and if they don't have any symptoms with a blood pressure of 95, we don't do anything about it at all. But let's say they've had a blood pressure of 150, and all of a sudden they have a blood pressure of 95. That's a big change. And so, but we have patients who have blood pressures in the 200s. And so what we try to do is bring down their blood pressure slowly, gradually, because they're used to a very high blood pressure, and so their brain is used to high blood pressure. And but by bringing it down slowly, we don't affect changes within their brain, which can.
I want to talk to you about medicines, because generally you go to the doctor and say, well, you need some high blood pressure, I think. But is there sort of things that people could do locally to look after themselves as individuals to help ensure they don't have to be taking a tablet for this, a tablet for that, and the list goes on?
Well, I think it may be a short list of non-medical things that you can do, but it's an important list. And so it's a list of, exercising routinely, not eating excess salt as well. So salt drives up your blood pressure. And then, eating the right foods as well too. But I think exercise, low salt, eating the right diet as well too, reducing the amount of sugar that you take in as well too, because sugar is a toxin as well.
It could lead to diabetes.
Right.
Absolutely. So that's definitely something to look at, because usually you go to the doctor and in a lot of cases they say, well, you need this medicine, that medicine. But there may well be instances and cases where individuals can say, I need to look after myself too, and to use the right kind of local foods or whatever the case might be.
And with obesity comes sleep apnea. And so individuals who are obese typically may have sleep apnea. And so that's a condition where the individual, when they're sleeping, they have apneic spells, where they actually stop breathing. And so these individuals...
You said stop breathing?
Breathing for a brief period of time, and then they start breathing up again. And so these patients often are obese, and they have an obstructive problem within their throat or their pharynx. And weight loss actually will help, and they often may need to have what we call a CPAP machine to go home with. So it adds positive pressure, and so we have to use positive pressure so that they keep their airway open.
That's really very important.
So these individuals actually end up with what we call hypoxia, so a low oxygen level, and we are we are not anaerobic organisms, and so we need oxygen, and so.
To survive.
Yeah, we really need to take care of ourselves. Huh?
Right.
Yeah.
That's really very important. And of course, now with the Juan Louis Hospital and all the changes with going across there and moving people, I think I saw something in the newspaper where there'd been an extended date for this change to take over with people going in. How has that affected your job in a very general sense?
I'm really looking forward to it. I think that we have great equipment in there and that we're going to be using, and really hospitals are really built, I think, around people. And I think that we have great people, within our hospital, and, movers and shakers. And I think that it's important for the physicians, nurses, and technical staff to stay engaged as well, too. And I'm excited. I've been here for 25 years and I'm still excited about St. Croix. And I think that, we have the chance, another opportunity to sort of go back into the past, and where we can bring services that we had in the past, such as nuclear medicine, nuclear cardiology. We had MRI at the hospital before. We had, we had 60 CT scans, and we still actually have that. But we're going to have a 128 slice CT scanner that we're going to be using, and hopefully we'll start doing what we call cardiac CT. So we'll be able to look at the heart, the structures of the heart, the arteries of the heart, without actually doing an invasive procedure.
Oh, really?
And so instead of doing
scans,
right,
That sounds really exciting.
Yeah. So once we can do that, we can determine whether somebody needs further care as well. So we oftentimes we do this as what we call a triple rule out. We rule out pulmonary embolism, which is deadly. We rule out aortic dissection, which is deadly as well, and also coronary disease, all in one scan. And so typically the patients would present with one of those complaints or symptoms representing those diseases, then would do the CT scan and would be able to rule out 3 of them in one shot.
So, Dr. Galiber, what types of symptoms would we need to look out for? I think when we get to be a certain age, we start to think about our heart and our heart health and how we're doing. And if there was a problem, what would we notice?
A very good question. I think that, as physicians, what we need to, or what we do, is we ask open-ended questions. And so one of the questions would be, what has changed with you? And so the patient should take note of what they can do and what they've been able to do in the past. And so patients may say, Doc, I used to be able to walk up a flight of stairs, but now I can't because I'm short of breath. And so that would lead me to think that. So shortness of breath is a symptom, chest discomfort or chest pain, or squeezing in their chest, and diaphoresis or perspiration. And so individuals just don't start perspiring, and also feelings of impending doom as well too. So that's a really scary thought, and most people impending doom, and so patients just gosh, I just feel that something bad's going to happen to me, and oftentimes it's nondescript. They cannot describe what it is, but you can tell. You can look on their face and say that, and see that they're in crisis.
Is that a sign of a potential heart problem or heart attack?
Yeah.
The sense of impending doom.
Right.
That's interesting. So I was going to ask you to kind of discuss cardiac or heart problems in the context of panic. I know a lot of times people who have panic attacks think that they're having a heart attack, and so they present to the hospital and it's a panic attack, and they have a strong sense of impending doom, right?
Right, that is true.
So for me, it makes it harder for me to distinguish, but I don't think we necessarily need to distinguish. We need to go to the doctors.
Correct.
Yeah.
Right. And oftentimes patients come to me and they say, well, I ask them, well, so what brings you to my office or into the hospital? And they say, well, you're supposed to tell me. And really, the patient is supposed to tell you. And then you interpret what they tell you. So, and it's amazing that they probably have never read a textbook by Braunwald, who is the authority in cardiology.
Braunwald?
By Braunwald. Eugene Braunwald. Braunwald. And so he wrote, one of the key textbooks in cardiology. But these patients know exactly what's in it because they know the symptoms. And so what has happened is that we've studied patients. We know what their symptoms are, and we put it in the books for us to be tormented, to learn. And once we learn it, then when the patients come in and they present, typically they present with the same symptoms. And so,
How many more people besides yourself are in this
In cardiology?
Yes, business.
We have one other physician in the hospital, Dr. Rubin. He's in the hospital, and so he's a cardiologist as well. And we have other physicians too. Dr. Sazef, he's through Dr. Prasad's office, and then Dr. Sayan, who's with Dr. Chase. Yeah.
Is that enough for St. Croix?
Well, it's a challenge to see. I mean, I am pretty busy in my office, and we try to, and I think one of the key things, I often share my cell number with my patients, and so because I think it's really tough just to see them once or twice a year. They may have questions, that they may want to ask as well too. And so I think it's important to keep in touch, and so we review all of their X-rays and EKGs and their labs as well too, and then we evaluate them as well for certain conditions that they may have, and follow up with them too.
These younger people generally, are they getting trained in the areas that you work in? I mean,
you mean, do I have a replacement?
Yeah.
I certainly do hope that I have a replacement, because when I first got here, I figured I could work forever, and I'm realizing
got here from where?
I'm from here, from St. Croix originally, as you know, but I spent 13 years away.
Oh,
and
I see.
So for undergrad, I went to Howard University, undergrad.
My alma mater.
That's right, and a great school.
Yeah.
And
my alma mater is UVI.
Well,
That's
actually,
a great school.
I must go back a little bit as well. I did my first year at UVI in St. Thomas.
Oh, I see. Yes.
And then I was an early admission student. Then I went to Howard. I transferred to Howard. I spent 3 years, 1 year at UVI in St. Thomas, and 3 years at Howard. And then I went to Indiana, spent 7 years there.
Oh, yeah?
Did 4 years of medical school and 3 years of internal medicine residency. Then I went to the University of Kansas in Kansas City, Kansas.
Wow.
And so I left in 1995.
Oh, I
So,
see.
yeah.
And then came here.
And came here, right.
ever
So I
since.
came here with my wife Yvonne,
Yes.
and we have one daughter, Dominique, and Dominique is, so yes, she is a she is a replacement for me, yes. So she's not in the identical field, but she's going to be a nurse.
Oh, she's going to,
Yeah, so
So
she's
she's
a
going to be
nursing
taking
school,
care
right.
of us.
Yes.
Yeah.
And the nurses do probably at least 51% of the work. And so,
Oh, I see. Yeah, to pull things
That's-
together, that's
yeah.
really very important indeed, because we have to have replacements as
Right,
we go
right.
along.
That is
That's-
true.
that's very
And my
true.
father was a radiologist. My mother was a nurse as well. So
Yes. So you've been in
Right.
that thing. And your brother has
I have two brothers who are radiologists, and
Oh,
I have
yeah.
a younger brother who runs a CT scanner. And so we've done actually I should say our forefathers have done their job
Right.
in getting us back, and now we have to do our job in getting
being in the medical
individuals to-
field quite a bit.
Yeah.
So, Dr. Galiber, so much gets centered around the heart, and a lot of emotion also gets centered around the heart. Is the heart where we feel emotion, and can you talk a little bit about broken heart syndrome?
I think the brain really is where you feel the emotion. I think the heart is the
We kind of refer
the
it there,
attractive,
though.
right.
We refer it
Yeah,
to the heart.
Right. I think the heart is the attractive one, and so I think that probably in the olden days we didn't really think of the brain at all. We thought of the heart and this mysterious organ and what have you. And I pay homage to Dr. Daniel Hill Williams, who was one of the first individuals to actually operate around the heart. And so he, back in the late 1800s, he was an African American surgeon who actually built the first hospital in the United States that actually catered to black and white patients. There were no other hospitals that did that. So but he actually took care of, and the patients survived. A number of people have operated on the heart, but they didn't survive back then. And so this one patient was stabbed in the chest, and so he had a pericardial effusion, so he had fluid around the heart that was compressing the heart, and it's an emergency. You have to go in there and drain the
I
heart.
would think it's an emergency.
Right. So so back then, I mean, they didn't have all the stuff that we have. So you have to imagine a time where you're probably doing surgery in a basement, and there are probably other critters within the room too. And that's what it was. And they didn't have individuals who could be intubated. They didn't have endotracheal tubes and what have you. So these guys, so he was a master anatomist as well. So he knew the anatomy. So he would actually, there are no x-rays, by the way, or if there were x-rays, just plain films.
Yeah.
No CT scanners, no MRI or anything like that. And so this gentleman actually survived longer than he did. Whereas he lived maybe another 30 or 40 years, the patient.
I want to bring you back to the broken heart.
Yes.
Because that's what and I'm glad this came up. Because
there's that whole broken heart syndrome about where it damages your heart.
Yeah.
Right, exactly. Tell us about
and
that. Because it does feel like your heart is breaking.
Right.
Yeah.
So what they think occurs is that when somebody has emotional stress, they have lots of epinephrine and norepinephrine circulating in their bodies, and that may actually cause direct toxicity to the muscle. And so it's similar to what people have when they use cocaine.
Yeah.
And so there's direct toxicity to the muscle of the heart, and they have this thing called contraction band necrosis. And so necrosis is cellular death within a living tissue. So the muscle cells of the heart are dying.
Yeah.
But the arteries are actually normal. So when we do the heart catheterization, we see, the arteries are normal. Why are you having a heart attack? Well, we've discovered that individuals who have severe stress, emotional stress, loss of a husband or a wife, or death, of an individual, a loved one, they can have severe discomfort, chest discomfort. I've seen a number of patients like that, and so they actually have direct damage to the muscle of the heart itself.
So we have to be careful when we're falling in love and things like this, and think about our hearts.
Well, even more careful when you're falling out of love.
That's it. That's the problem right there, right? Falling in love, no problem necessarily, but shoot, how am I going to get out of this?
Right.
Yeah.
Or get out of it slowly.
Right. Slowly back away. Yeah. So I wondered, in contrast to that, when is the heart happiest? When is it more relaxed?
When is it more relaxed? When you're sleeping. Yeah. And so the heart rate typically goes down, decreases when you're sleeping. That makes sense. So everything sort of slows down, and the body is sort of like a computer or like a car. I mean, when you start up the car in the morning, it takes a little while for the engine to turn over. The same thing with your body, and you have to stretch and do all sorts of stuff just to get back to baseline. And so the heart. And that's a very good point, because most individuals have their heart attacks actually in the morning.
Really?
It's a higher risk.
What time in the morning?
Well, whenever they wake up. So in other words, if you sleep during the day, then you wake up at night, and so there's a circadian rhythm.
Yeah.
And so the same thing with asthma.
Right.
So they have typical asthmatic attacks, typically when they're waking up. And so you can sort of think that the brain is like an engine that's sort of
I'll tell you what I do in the morning is, let's say I get up around 4, wake up.
Right.
Then I take 10 deep breaths.
Okay.
And I count, for one deep breath, I start to count in my mind, 26, and then another. And then after that, I fall back to sleep again. And I'm thinking of trying to get some oxygen and so forth inside my body. Yeah. Is that a good practice?
I think it is, but it's probably better if you just stay awake after that. I mean, you're getting up in the morning, right? But I made note that you went back to sleep.
So I attended a presentation yesterday on sleep, and one of the points that and I'm going to share it with you, Dr. Pittman, who we had on, gave the presentation.
Oh, yeah.
But one of the points that he made was about hitting the snooze button. And he was talking about the fact that when the alarm goes off, it kind of jolts our heart, right? It jolts us awake. And then when we hit the snooze button, and we go back to sleep, we're kind of jolting ourselves awake, and cumulatively over time, how this could have such a huge impact, and it's better to just get up.
Right. That's true.
Yeah. So maybe waking up slowly is a better way to do it rather than by alarm clocks.
Probably so. Yes, I would agree.
And to prevent heart attacks.
I saw something where it said when you get up in the morning, just sit down on the bed for around 2 minutes before you actually walk and go around and things of that particular nature. So, well, thanks for this very, very interesting discussion about our hearts, and we need to really look at them and try to keep this heart going for as long as possible. 90 years, 101. There's people living 101.
That's
what kind of hearts they got?
They have very good hearts. They have very good hearts. And I mean, you don't, you're born with a particular heart, but you don't have to die with the same heart, because we actually, if your heart gets really bad, we can do a heart transplant.
Or you can put some sort of equipment
device,
inside.
Right. But we advise you to keep keep the heart that you
Keep
came
the
in
heart,
with.
yeah,
And so,
And take care of the one you have.
yeah,
Yeah,
keep the heart that brung you. You know, so, yeah.
And be careful with falling in love and so forth.
Well, I would leave that probably for another conversation. So,
All right. Well, I just want to thank you so
Well,
much
thank
for
you.
sharing
Thank
some
you both.
good
Thanks for having
ideas
me.
there.
So-
And I hope that at the hospital, as you open up, you get all the equipment and supplies needed to really make us 100% in terms of people don't always have to feel that they have to go away
Right.
to get care and attention.
that's
it could
key.
happen right here in the beautiful island of St. Croix with the Galibers making things work.
well, thank you very much. And it's really a team effort, and it's the Galibers plus everybody else who's
Right.
doing an excellent job at the hospital. And so
But you all
yeah,
do so much.
so-
You do scans, you do all the
That's
other
right.
things that you
Never
do.
know.
Right,
Coming
that's
up.
right, yeah. And
Taking good care
Well,
of
But
it.
you're just doing what you came to do.
right,
Okay?
yes.
Thank you very much, and I just want to thank our good friend Earl Morris, and of course our other good friend Mr. George, for keep us rolling, and we'll be back with you again with another interesting program in terms of moving forward. That's our main goal.